Real honor to be here today. I'm a house call doctor, so they still exist, and I make house calls to my patients in Boston, and really honored to talk to you today about the future of acute care and building home hospitals. These are my prior disclosures, nothing relevant for today. So I want to just outline, I think with talks, it's nice to have a few kind of pieces or frameworks around what to take home. I feel like I spend a lot of time talking to my family and friends about what do I actually do. And so I want to describe home hospital and kind of give you a sense of what that means. I want to teach you how to build a home hospital program. What does that look like tech-wise? You know, how do we actually assemble the clinical model and strategic model? Is this too loud for you guys? Okay. Yes? Let's see what we can do here. Is that better? That sounds better. So building kind of a technology model. I want to show you how to possibly scale a home hospital program and how would you think about building acute care at scale in the home. And both capture the promise and the challenges. So I think it's a really exciting time. I'm going to talk about our new paper that just came out in the Annals of Internal Medicine in 2019, but we're still kind of at I think both an exciting time and a challenging time in terms of thinking about some of the future. So before I begin, I like to start, this is a quote I live by, the art of medicine has its roots in the heart. And so, you know, for me, it's really about loving and taking care of our patients and serving them in a meaningful way. And I think home hospitals are a really tremendous way to do that. I get to sit on my patients' couches in their homes. I get to meet their pets. I get to see their family photos and take care of them at a time where they're really not well and do that in a really meaningful place. So although I'm going to talk to you a lot about the science of delivering and building a model, to me, it's really about, you know, bringing the art back to medicine and, you know, bringing the house call into kind of a new dimension. We're going to start off with a little bit of fun. It's a small enough group here, but, you know, where are we? Anybody have an idea? I know there's 4 photos, but in general, if you were to pick, where are we? Hospital, right? And we're going to go through each photo quickly. What do you see in each room, starting at the very, I guess on my side, the top right? What do we see? We see a bed, a side table. I don't know if anybody sees a lamp, maybe a water jug. Anybody know what year that is? 1940? Okay, not bad. 1920. We're getting there. Let's go to the next photo. It's not great, but there's actually a window in this one. Any guesses for what year we're in? 1970, not bad. 1960, we're getting close. So we have 2 beds in the room now, some side tables. Let's go to the bottom right. What do we see? Same thing, right? You know, bed, side table, chair. We've got some curtains, so we're becoming a little bit more innovative. There's actually patients, but you can't really see them. Any guesses on the year? 1980. Excellent. Yep. And then we're moving, you know, to the final photo. We now have gone back to a single bed. We have a larger window. Any guesses in terms of time frame? So 2015. This is a hospital, really big academic center in California. But there's a lot of things in common in all these photos, right? We have a bed. We have a side table. We a lot of times have a lamp, maybe a water jug. But basically what I'm getting at is in the last 100 years, we have not changed how we take care of acute care patients. So we haven't really figured out, you know, a different structure to do that. We have the nurses and doctors round on them, and kind of the setting that we've built is the exact same. So we've innovated our medicines, we've innovated our kind of imaging and our structures, but the place that we take care of our patients is no different. So that's what bringing home hospital is. And so I want to provide a definition. Sorry, that's a little bit small, but basically it's you know, a community provision of services that generally would be seen kind of or you know, used in an acute care setting. And there's kind of 3 models, and I'm going to talk about one of them in detail, but The first model is early transfer. So this is a patient admitted to your hospital wards, spends a day or two in the hospital setting, and then is transferred early to kind of continue their acute care. So that's an early transfer model. Substitutive with the ED is what I practice in Boston or at Brigham and Women's. So this is a patient that comes into your emergency department, is seen and evaluated by an emergency department physician, and is deemed to need acute care medicine. And instead of being, sent up to the ivory tower at your hospital, they are admitted to the home hospital service and receive their acute care at home. Where I think we're heading actually is substitutive without the ED. So this would be a patient that's kind of evaluated in a primary care clinic, subspecialty clinic, that's deemed to need acute care medicine. And instead of ever hitting the four walls at your hospital or emergency department, they go directly home with acute care hospitalization. So why are we even here? Why are we talking about, what's the problem with hospitalization? We do a lot of great care in the hospital, but I'm going to argue there's actually a lot of unintended clinical consequences. 1 in 5 older adults becomes delirious in a hospital setting. 1 in 3 loses functional capacity. This is an older adult, loses functional capacity that they never regain. And 1 in 10, anybody in this room who hits the hospital wards will have a adverse medical event. Could be a medication error, could be a fall, you could get an acquired infection. So, it's not without risk. Number 2 is we have a lot of poor patient, access. So I practice in Boston. I feel like there's a hospital at every corner, yet we're at 100% capacity. If many of the clinicians know that, if any of you do rounds in the emergency department, you're looking to wait 12, 14 hours, lots of patients in the hallways, so we can't build beds fast enough in the inpatient setting. And number 3, it's the most expensive place to take care of patients. So I think for those very reasons, we need to think about innovating and building a new structure that looks a little bit different than the 1920s. So I think this is where I think this is a really important slide, and this is kind of, I think I spend a lot of time, as I joked, describing to people what I do, because home hospital, it's a relatively new concept. But, on the far kind of right side, you have the super acute, and then on the far left, you have telemedicine. And it's really about getting the right care to the right patient at the right location at the right time. That's what the model is all about. So I don't operate an intensive care home hospital model. Our goal is to basically find patients that typically would be admitted into an inpatient setting and home hospitalize them. Then you kind of go to rehab and then home health. And so I think the big difference between home hospital and home health, it's really about acuity. We're dealing with an episode of acute care versus home health. You're also kind of meeting the patient at home, providing excellent care, but it's on a much more longitudinal basis. So there's been a lot of, this is not a brand new concept, although I think we're getting to an exciting time. Home hospital or hospital at home, as you might hear it in some of the literature, has been around for 20 years. And there's some really nice data published by these 2 studies up top, basically showing that the quality of care, the safety of care was the same. And they also showed a 20 to 30% cost reduction. Really awesome work, really exciting to validate the concept that we can do this safely and provide quality care. What they didn't do is they didn't randomize the study. And one of my colleagues, Dr. Levine, published the first randomized trial. This was what got me really excited and interested in 2018. It was a small study, 19 patients, but showing a 52% cost reduction in our hospitalization versus traditional hospital. And I'm going to discuss our follow-up study, but very similar aims. The follow-up study is a parallel design study, very similar. But basically it was to compare usual hospital care kind of with the home hospital model. And for those clinicians in the room, I know this is always interesting, but our primary outcome was cost. So we wanted to prove that we could reduce costs by 20% with this intervention. Of course, we wanted to maintain safety and quality of care, and our hope was also to improve quality of life and patient experience. So this is relatively hot off the press, 2019 of December. This was our larger randomized trial, and it was published in the Annals of Internal Medicine, and I'm actually going to go through a lot of our data to kind of show our model in more detail. And we'll kind of go through this, but basically there were 248 patients that were presenting to the emergency department that were evaluated. I will bring up one thing because it is a limitation in the study, but 157 of them said no. They didn't want to be hospitalized with the home hospital program. So of the 91, we then randomized 43 into the home hospital arm and 48 into the traditional usual care. So home hospital arm, you get taken care of by a home hospital doctor like myself. Usual care generally is by an internal medicine doctor, sometimes a cardiologist at our hospital. So let's kind of go through the workflow. What does this look like? So patient lands up in the emergency department. The emergency department does what they do really well, which is they triage. The good news is, if you don't need to be into the hospital, the first kind of decision tree is you get discharged. I always joke that's the best outcome. As much as I want to see you, if you can go home and directly home, that's even better. But if you happen to need a hospitalization, we then, and I'm going to go through some of our criteria, if you met our criteria, or if you didn't meet the criteria, you were directly admitted to the hospital. If you met our criteria, you were randomized either to usual care or the home hospital care, and I'm going to talk in detail about our model. I feel like we do a lot of bread and butter internal medicine, a lot of fun stuff, but we take care of cellulitis, complicated UTIs, a lot of pneumonia, lots of IV antibiotics. I do heart failure. I've had heart failure patients lose 30 pounds on IV diuretics at home. And then, asthma and COPD, and I'll show you a better breakdown in our actual study, but just so you kind of have a sense of our conditions. So what are the inclusion criteria? Because I think this is something we've been, that beyond our study, we really still utilize if you're thinking about building your program. So we wanted to develop a radius. It is Boston, so even a few miles can take a little bit of time, but developing an appropriate radius. Ours was 5 miles, and we have 2 hospitals. We have kind of Brigham and Women's, which is the main academic center, and I also admit patients out of our community center, which is Faulkner. In terms of the clinical criteria to be involved, you had to be an adult. Our program's done anywhere from 18 to 108, so we take care of a lot of older folks. And you had to meet one of our primary diagnoses. So I showed you a few of them, but in the study data and tables, I'll show you a few more. So what were the exclusion criteria? And I was really inspired by some of the talks yesterday, but you actually have to have a home. The work that's being done in terms of housing as medicine, I'm really inspired by. But in our study, unfortunately, you had to actually have a place to live. If you lived in a skilled nursing facility or an acute rehab, we didn't take you. We also wanted to make sure that your place was safe, so we screened out for domestic violence. In terms of some of the clinical criteria, I know it sounds silly, but we wanted to make sure that all our patients had peripheral access. I know most people think once you have the peripheral line, it clots up immediately once you leave the hospital. That's not true. It works really, really well. That was something important. We wanted to make sure we had that in case we needed it. In terms of some of the secondary conditions, we don't do kind of dialysis in the home yet. So that was an exclusion criteria. And then some of the things about, kind of high-risk patients for clinical deterioration. You could imagine an asthma patient who's had multiple kind of intubations, uses one of those masks occasionally. We wanted to make sure that we had the ability to safely take care of these patients and that they weren't going to head into an ICU condition. So what does our team look like? I feel really blessed. I have some amazing nurses, and they have to deal with me every day. I travel with them in the car, but they make 2 visits a day, and we don't see our patients at 6 a.m. We see our patients at 9 to noon. We really believe in them sleeping in, which is really great. And so our nurse kind of comes twice a day. We typically do 2 visits, and that's what the study does. I make house calls. So I see the patients in the morning generally, and if they had any sort of acute care need, I am available, believe it or not, 24/7. So not the most sustainable, but we're building a new structure for that. And then we also kind of have a team of additional clinical resources, physical therapists, social workers, excellent, if a patient needs a home health aide overnight, we can provide those services as needed. So I think we have some really cool diagnostics. I don't know how many of you practice in the hospital, but I can do blood work in 2 minutes, which is pretty amazing. We use a device called an iStat. It gives me blood work in 2 minutes, a Chem 8 and an H&H, so can make relatively quick clinical decisions, and I don't have to wait hours for the blood work. We do point of care ultrasound, so we can kind of look at imaging in the home. If the patient does need it, we do x-rays occasionally. In terms of our pharmacy, in terms of the acute care medicines, we have a relationship with our inpatient and outpatient pharmacies to get kind of acute care medicines available. We do utilize the patient's actual chronic meds. So I spend a lot of time looking at their meds and hopefully getting the right med rec. I think it is a valuable piece of the puzzle. And then I have this really crazy 30-pound backpack with just about any acute care medicine that I think a lot of my Uber drivers wonder what is in there. But it's for immediate and urgent needs. So that's kind of our pharmacy supply. So we don't have our patients walking around their home with, kind of a pump. We have this cute little pump. It goes into this, kind of black bag, little purse. They can walk around. They're much more mobile. And we can infuse medicines at all hours, 2 a.m., 3 a.m. As I mentioned earlier, all of our patients do have peripheral IV access, and we do provide home oxygen. Communication. As you can imagine, we're building a virtual home hospital. We need to be able to communicate, and we need to do that really, really well. And so we use various applications. The top one is an application called HIPAA Bridge, which is a secure HIPAA-compliant texting application. We also use, if you guys are thinking about different uses, Microsoft Teams right now. We use for our team for kind of shared task management, we use a application called List Runner. So it helps to kind of keep patients in order. We can have tasks on our team because we're all on the go and mobile. We do encrypted video. So I always love it. Every one of our patients has an iPad. I love when I go to my 86-year-old patient, she's like, what is this on my side table? What do I do with this? You can video visit me. So normally that doesn't work out, and we just say, don't worry, just give me a call. So believe it or not, in today's day, telephone is still our best form of communication, and I think really important for the operations of our program. We also monitor our patients 24/7. So we use a company called Vital Connect. It's a little sticker patch. It goes right on the patient's chest, and they can be monitored. So it does telemetry, 24/7 telemetry. Don't worry, I monitor the alarms. And it does vital signs, so heart rate, respiratory rate, whether they're sitting down, lying, standing. We can detect falls, and it's an activity tracker, so we know how many steps they're taking. I always joke, don't worry, I can't see or hear you, whenever you're sticking on a device. So let's get back. I'm sorry that's a little less clear than I was hoping, but let's get back to the study. And I'm going to do a little bit of a deep dive, but with the hope of not boring you guys with the details, but providing some insights with regards to the 2019 study. So as you remember, 43% or 43 patients in the home hospital arm, 48 in the control arm. If the top line is the age, so slightly younger patients in the control arm. Because we were, asking patients, if you remember that first diagram in terms of the study flow, we had 63% say no, and part of that is they were being, asked whether or not they wanted to be home hospitalized as they were being rolled up, because we didn't want to make sure that there was a delay in terms of the emergency department. But there was a much larger percentage of females in our study that said no. The control arm, there was a higher percentage of African American patients. In terms of caregiver support, which I think is something really important to think about, a relatively similar mix. Although one thing I'd like to point out is about 25% of both groups lived alone. So, whether or not they lived alone, both of them, kind of an equal amount there, which is important. And if you get to the bottom in terms of payer mix, there are slightly fewer Medicare patients in the control arm. So in terms of, education, we kind of break that down. We're in Boston, so a lot of mix in terms of lots of schools, lots of education. So we had a pretty nice mix in terms of patient population. Most of our patients were relatively frail. These aren't your healthy patients. They have multiple comorbid conditions. In terms of functional capacity, we did a number of scores, if you look at the study, but functionally they were, generally pretty frail, as I mentioned earlier. One thing that I thought was interesting is that the code status for the control arm was much higher than the home hospital arm. And there was a little bit more home health support in the home hospital arm. So not a surprise, but infection is the number one diagnosis we admit. We do a lot of pneumonia, a lot of soft tissue infections. There's a little bit higher number of cases of diverticulitis in the hospital arm. Similar rates of asthma or acute respiratory conditions, similar rates of heart failure. And if you look, this kind of provides an overview of all the types of conditions we treat: complications of diabetes, end of life, hypertensive urgency, and gout. So let's get to some of the utilization, because I think this is what people are most interested in. How is home hospital moving the needle? We do have slightly longer length of stay. So that is a point to be made. It's 4.5 days versus 3.8. I will argue, when we look at some of the other data, that there's some real value to that. We overall are still much cheaper, and we have fewer 30-day readmissions, but that's something important. In terms of imaging, we use a lot less imaging in the home, 14% versus 44%. We stick our patients a lot less, 3 average lab orders versus 15 in the hospital. And in terms of consultations, 2% versus 31. So we're utilizing a lot less care. We did look at the 30-day acute care readmission rate. That wasn't kind of a primary aim of the study. But if you compare the two arms, within 30 days, it's 7% for the home hospital arm and 23% for the hospital arm. So it's a pretty big, significant magnitude of difference when you look at the 30-day readmission rate of home hospital patients versus the traditional hospital care. In terms of quality of care, and safety of the events, 9% of the home hospital patients, and in the next slide I'm going to show you, had an acute care or adverse event versus 15% in the hospital arm. Patients, this is hard to see, but I always think this is kind of interesting. So in terms of sedentary, 12 or 13% were sedentary in comparison to 23% of the hospital. And in terms of lying flat, if you're rounding in the hospital, there's a really good chance your patients are lying in bed. 55% of the hospital patients spent their time lying in bed. The one interesting thing is, despite the increase in movement, there was no change, or there was kind of a similar decline in functional capacity for both groups. And patient experience was very similar. So I just wanted to bring up one point, because it was something that we found kind of interesting in the study, is the rate of delirium in the home hospital patients versus the hospital patients. We were hoping that, or we were curious or thought that there would be a difference, but it was actually a very similar rate. And one of our thoughts around that is that any type of acute care illness could cause you to maybe have an increased risk of delirium. We also, one of the other hypotheses, I wasn't practicing at the time here, but was that the physicians basically identified delirium a little bit more frequently. So here's just a quick overview. If you take anything away, I think this is kind of a nice slide. Lot of decreased utilization in lab orders, imaging, consultations. Our patients also didn't go back to the hospital. We had 0 transfers back to the hospital in terms of our acute care patients. So, as I mentioned earlier, our primary goal in terms of the study was to show a cost reduction. Our mean adjusted reduction in cost is 38% compared to the traditional hospitalization. So pretty significant. If you look at some of the possible reasons, there could be a difference in our staffing ratios. We have kind of a different nursing structure than the traditional hospital setting. Many of our patients are utilizing less resources, less imaging, less labs, less consultations. We do have increased movement, but once again, the functional capacity of patients are both declining in both studies. And patient experience and quality were the same. So we really kind of achieved our aim in the study. And I can tell you from just personal experience, I have never had happier patients. They really, really enjoy being at home, especially when you're not well. You get to eat your own food. Don't worry, I don't cook for them. That would not be a good thing, but they get to eat their own food, be around their family and loved ones, and the experience, I think, overall is really wonderful. So what are the challenges? Why aren't we doing this everywhere yet? Australia, 10% of their 10% of their hospitalizations are home hospital. And the reason that is because they pay the exact same rate for a home hospital case as they do for a traditional hospitalization. Spain has an 80-bed virtual unit, also kind of similar payment structure. So lots of other countries, we're really behind the 8 ball in terms of innovation in home hospital. But I think the major challenge is we don't have a payment mechanism yet. I will shed some light on some possible thoughts on where, or depending on where you live in the world and kind of the work you're doing. There are Medicare Advantage groups doing this. It makes a lot of sense if you own both the delivery system and kind of bear risk and have a capitated model. I think there's going to be a lot of academic centers like Brigham and Women's that are at 100% capacity, that think about the right care at the right location at the right time, that say we want to increase our case mix index. And we also have some commercial contracts. So I think some of the commercial payers are starting to realize that this is a really great opportunity to take care of patients in a meaningful way. It's safe and we can reduce cost. One of the major challenges is the delivery model, right? So you can order a pizza, you can order just about anything, but to get oxygen to a patient's home in a timely fashion, to get labs to the home, to kind of provide a pharmacy delivery structure, we haven't built the Amazon yet to get there. And that kind of brings that logistics, right? It's a little bit different. When you have everybody under one roof, it's easy to kind of change course. In the home hospital setting, that's a little bit more difficult. So I think you really have to think about the logistics platform for this. And finally, I think the major key is technology. Nobody has this full suite of services technology yet. I think once payment models come and people really are getting more excited, there's currently 14 programs in the US, and I think there's going to be a number of them opening up. It's definitely an exciting space. So today the goal is to really reimagine the future. As you saw on that first slide, I think we can do better than the bed, the side table, and chair. I think there's a real opportunity here with the right clinical design, the right technology, and the right kind of payment structure to really build the future of acute care and take care of patients, as I mentioned before, in a really loving and meaningful way. That's my email. Really honored to be here today. Thank you guys very much, and hope you're inspired to come away and think about the future of what acute care looks like.
Thank you, Greg. And
I was going to say that was fascinating and inspiring. I actually have a question myself. Are you getting paid at all right now for doing this model?
So the way our current payment structure works is I do bill for house calls. So that's kind of our operating model. And then the hospital has invested. Brigham and Women's is part of Partners Healthcare, which is also changing their name. But basically, long story short, they have a pool of funds in their population health management group that they devote. And so they're paying for a lot of the services and believe that this is a real opportunity. So we're at max capacity. We should be taking care of cardiac casts, really advanced orthopedic surgery, neurosurgery. The pneumonia cellulitis can be done really, really well at home. And I think the groups are realizing that this is a real opportunity to do that.
Yeah, it's very inspiring.
So, yeah, questions. And I did want to mention also, a few people have asked me, we do have Greg's slides, and they're going to be up on the app very shortly.
Dr. Goodman, outstanding study and presentation. You mentioned monitoring patients, movement, and
Yep.
other vital signs. How did that work?
Sure. So we use a company called Vital Connect, which is that kind of patch. And so that patch just kind of connects to a tablet, and it's a small little device, like hardware device. It measures kind of a live EKG, heart rate, respiratory rate. We do have the ability to actually do remote blood pressure and oxygen. I think if they're that sick and we're worried that much, then they're probably not best served in a home hospital setting. And then I think in terms of the tracker, it's most useful, I think for us to detect falls. So I'm not exactly sure of the technology, but I think if you have a quick movement in terms of, falling, it's been pretty accurate. We have had, unfortunately, an event or two, and it can detect that. Very, very useful, and I think important in terms of your ability to operate a program like this safely.
Other questions?
Thank you. Great presentation.
Thank you.
Do you have any thoughts on how we could do this for homeless patients?
I think that's an excellent thought. I'm a big proponent of, I think yesterday they presented some of the models in terms of the transitional housing. I think that would be possible, if you had a place that you could safely kind of put a patient and provide them, with a few days of, a bed and an opportunity to kind of see them in a thoughtful manner. But we have not really explored that at great detail. But I think it's a really exciting and meaningful place to innovate in this model. And I think it's important to provide this service to everybody. And as you guys saw, we're payer agnostic. We treat everyone, which is really cool.
I'm just curious, on your daily, the nursing visits, what was the role of those nurses during those visits? What did they do?
Sure. So a typical rounds, we have a few nurses that I round with. So I think it's kind of a team-based approach. We'll go visit the patient, collect the vital signs, administer medications, prepare IV, therapies, prepare diuretics, draw blood work, kind of similar to what you would have in a traditional hospital setting. And I think we kind of split up the work. It's a very team-based approach. I have no problem drawing labs, making the medicines and, kind of participating on that. But I think the main role is, kind of the similar traditional kind of nursing role during that visit. And then the nurses see the patients in the afternoon by themselves. And we have the secure kind of platform for them to message or, kind of interact with me in a way that's meaningful. So there's kind of a combined visit and very autonomous, approach in terms of nursing.
Sorry. Hi. Great presentation.
Thank you very much.
Very inspiring. What is the communication like with the PCP?
Sure. I think, many of our patients, depending on where they're located, we try and, connect the PCP. If they're in our system, I send them my history and physicals, so they're very well aware of what's going on. We definitely try and rope them in as early as possible, just like any, I think, group in terms of trying to make sure that many of our patients, and I think it was in here, but I didn't present it, but most of our patients do have a, closer PCP follow-up within that general time frame. So we really try and do a good job of connecting both the acute care episode with the outpatient, teams, and think that's really important. So try and engage as soon and as early as possible.
Do you know if anybody's using APPs instead of an MD to make the house calls?
Yes. Can you hear me?
The question was,
so I think
is
the
anyone
question was-
using APPs for the
So kind of
house call?
advanced, practitioners, nurse practitioners, physician assistants. So partners is a very, interesting. We operate two separate models. Brigham and Women's has their own, and we have our own. They do use advanced nurse practitioners. We have not done that yet. I definitely think there's a tremendous role in using a care team and building a structure, and I think they can, really participate in a meaningful way, and I think it could be kind of part of our scaling efforts.
I have another question.
Sure.
On the readmission
Uh-huh.
data, you said there were no readmissions for the people that were
So
hospitalized
there are
at
no
home.
patients that return to the hospital. In terms of readmissions, like, are you talking about within the 30 days, the difference
Yes.
was 7% in the home hospital
Yeah.
arm versus 23%. But during I think the confusion, maybe the confusion in the way I presented was, it was during the hospital stay, nobody returned to the hospital during the episode. So they received all of their care in the home hospital setting.
Yes.
They didn't require, a visit back to the hospital for,
During their care.
During the care.
So what about true readmissions? Did you measure that?
What was that?
Readmissions for patients that were
So
in both
post-discharge?
groups, and they were discharged. You finished
Yep.
their care at home.
Yep.
They finished their care in the hospital, the other group.
Yep. So the 30-day readmission rate was 7% for the home hospital arm and 23%
Oh,
for...
okay.
Yeah.
Okay, and that includes patients that may have been readmitted to their home.
So, right, exactly. I see what you're saying. Yes, yes. So if they were readmitted or presented to the emergency department. So in the study, we presented kind of both, but yes, if their second hospitalization was a home hospital, we would have considered that a hospitalization.
And then finally, the ER doc, were they like blinded to this? I mean, did they just decide patient needs to be admitted and they had nothing, they were...
So they kind of carried on with their traditional workflow in the study, and then if they deemed a patient to need acute care, hospitalization, we actually then screen them ourselves. So if you remember the inclusion and exclusion criteria, we then screen them, and then if they agreed to participate, they were admitted. Okay. So our goal was to not destroy that workflow and be really kind to our emergency department colleagues. And so they worked up the patient like they normally would, and then we made a decision just like if you were to go up to the ivory tower, similar kind of option for the patient.
Okay, thank you.
Yeah, thank you.
Any other questions? I know this was a lot of people had a lot of questions for us when we were developing our agenda to bring somebody who's done something like this before. All right, I think we're getting ready for our break. Thank you, guys.
Thank you so much.
Thank you guys, really appreciate it.
Really
Thanks.
great.